Good morning. My name is Chris Rubish. I'm a cardiac nurse, and I'm president of the Minnesota Nurses Association, representing more than 22,000 unionized nurses and healthcare workers across the region. Today, we are here speaking about our ongoing contract negotiations for over 15,000 of our members and what healthcare workers are facing at the bedside. I've been a registered nurse for over 10 years, and over the course of my career at the bedside, as well as across my years of advocacy, I have seen a steady decline in the resources and staffing levels that we have to deliver safe, quality patient care. Year after year, nurses and our fellow healthcare team members are asked to absorb cost cuts and budget balancing by increasing our patient loads. More times than I can count, we have been told to get creative, or be flexible, or think hospital system-wide. But none of those responses focus on the needs of the patient before me that's in my care. For years, we have marched, we have rallied, we have shared our stories. We've highlighted Department of Health reports showing increasing numbers of sentinel events in our hospitals. We've cited peer-reviewed studies like this one showing that hospital expenses go down, not up, when staffing ratios improve. Like this one showing that hospital readmission rates decline when nurse-to-patient ratios improve. Or this study showing that hospital length of stays decline when nurse-to-patient ratios improve. Or this one showing that adverse events in hospitals decline when nurse-to-patient ratios improve. Yet even in the face of overwhelming evidence and firsthand experience from patients and workers, we continue to have this debate year after year. We can no longer ignore the real-world experiences of our patients and the overwhelming scientific evidence. We are fighting for concrete staffing language in these negotiations because this is what every patient deserves. As we approach Nurses Week, a week where we will celebrate nurses and caregivers, we will undoubtedly hear from hospitals and health systems across the state about how appreciated we are, how much we're trusted, and how much we use our skills and knowledge to care for patients. But when we speak up and advocate for the resources we need to safely do our jobs, we're told it's not possible. We're told it can't be accommodated in the budget. We're told insurance reimbursement rates don't account for that. So I'm going to close by reminding us of a quote from Florence Nightingale. She said, "I attribute my success to this. I never gave or took any excuse." And that is what we are going to do this year in our negotiations. Next, I am pleased to introduce my colleague from United Hospital, Caitlin Warren.
Good morning. My name is Caitlin, and I am a registered nurse currently bargaining for better staffing levels in my contract. I have been a nurse for less than 2 years, but like many of my colleagues, the violence and assaults I have endured in my time as an RN has taken a toll. While I have not lost my passion for the art of nursing, I am also barely surviving. My nervous system is in survival mode each and every day, leaving me little space for purpose, joy, creativity, or for that inner spark that made me want to be a nurse in the first place. I hope that sharing my story will enlighten you about the concerns regarding nurses' physical and mental well-being, which is at stake due to workplace violence. Everyone who becomes a nurse has their own personal reasons for doing so, but we are all here for the same reason at the end of the day: to care for humans of all kinds. And we do this no matter what the circumstances. No nurse enters this profession thinking of or expecting to be assaulted by a patient, but it happens far too often. And it is time for hospitals in the Twin Cities and Duluth to take action to ensure that we are protected. During my short time at the bedside, a day rarely goes by that I am not put in danger. I've been assaulted more times than I can count, physically and verbally. Pick a name, I guarantee I have been called in. I have had to have x-rays, CT scans, and numerous doctor's appointments, along with some scars to show. All due to assaults that could have been prevented with proper training, safety interventions, and staffing, all of which have been denied by my employer. I have had to confiscate knives from patients on my floor. I have been verbally threatened many times. Patients have made statements telling me that they will come find where I live, wait for me, and attack me. Imagine going to work and having someone threaten to punch you. Let me give you an example. During my last assault, I was kneed by a patient in my head. Why? Because they wanted to leave. It was just after midnight and I was the charge nurse on the floor. I heard a machine going off and saw two nurses run to a patient's room. I immediately followed them, and upon arriving, I witnessed a patient attempting to get out of bed, stating, "I need to go home." The patient was not alert and oriented, and they were a very high fall risk. The patient became more agitated, physically pushing me and my coworker away to get out of the bed. And we attempted every redirect and de-escalation tactic that we were trained to know, but it was still unsuccessful. To ensure that we kept the patient and ourselves safe, we obtained restraints until we could get the proper medication. As we began applying the restraints, the patient became even more combative in their confused state. And this is a common experience with patients that have confusion or delirium, which makes it even more difficult to restrain a patient safely so as to not harm them or ourselves. As we are doing this, the patient raised their leg and swung it back as hard as they could, violently striking me right on the left side of my head. I stumbled back, but didn't have an opportunity to pause, as I had to quickly jump right back to help get the restraints applied and keep everybody safe. That night, I was not given the option to leave, nor did the assistant nurse supervisor on duty even come to check on me or my colleagues. Instead, our manager chastised us for not calling it code green, which would have alerted security. But the simple answer is, I was not left with even a free hand to grab my phone and dial the code green number. All of our hands were concentrating on keeping the patient and ourselves safe. If we had an extra set of hands, we could have avoided this whole traumatic experience. The morning after was the worst. As I relived this horrible and traumatic event, I asked once again if I or my colleagues could get code green training to help us prevent this situation in the future. Could we at least get duress buttons for the staff? The answer is always the same. Online code green training is only available for charge nurses, and we cannot train the whole floor or get the buttons due to the clause. That is the quote. Between these responses and my manager telling me that I should have, quote, just let the patient fall, quote, let the patient get hurt, I can't blame my colleagues for leaving. As nurses, we are here to care for others, not cause harm. The excuses, empty promises, and blame shifting are just out of control, as the workplace violence itself. On my floor alone, code greens were recently up 300%. Would you feel safe going into your place of employment knowing that the risk of you being assaulted had increased by 300%? It is time for hospital executives to fix this crisis. We are here to care for patients, not to be human shields. And we cannot continue to do this dangerous work. We demand to be staffed safely. You cannot tell me that the significant cost of paying for workers' comp or the major turnover is less expensive than additional staff, proper training, or a better alert system, with the average cost to onboard a new nurse being over $82,000 each. It can't be just about the money. I'm fighting for safe staffing in my contract because I do not want to be the next tragedy reporters are covering. We don't have time for delays, denials, or deflections. We need real solutions and better staffing now. Thank you. I now introduce my colleague, Shannon.
Hi, my name is Shannon Morris. I've been an RN for 13 years. I spent the last 6 of those years as a nurse in our pediatric emergency department. We run a small 12-bed ER, and we pride ourselves on taking care of sick and injured kids in our surrounding community, as well as the complex kids from around the world, such as those undergoing transplants, oncology treatments, and other special populations that are not commonly cared for in other community hospitals. And yet, across our hospital, we're seeing an alarming rise in workplace violence. Nurses, techs, and support staff are being physically assaulted, verbally threatened, and emotionally traumatized regularly. Most of these incidents come not from medical emergencies, but from assaults by mental health and custodial care patients many of whom are not in our hospital for any acute medical need. At any given time, we have multiple children living in our emergency department and hallways for days, weeks, and months. Some of these kids are younger than 8 or 9. These are not psychiatric admissions. These are children in the custody of county systems or children whose parents have refused to pick them up because of their aggressive behaviors that they cannot any longer handle at home. These kids are stuck in limbo, and we're left holding the burden of care in a setting that was not designed or staffed for this. Let me be clear, inadequate staffing is not just a safety issue, it's a moral and financial emergency. Each of these patients require a one-to-one staffed center for safety. This is not a luxury, this is a necessity for the child's protection, for staff safety, and for the safety of other patients. And when I have requested the required staff needed to ensure that children are safe, my nursing supervisor had told me that my department is a drain on the hospital. We are constantly nagged by hospital leadership to reduce staff and to increase productivity to help with our budget. The not so subtle hint is that we will get fewer RNs and support staff to run our department. And when we advocate for patient safety and our own well-being, we are shamed for it. I've had more than one colleague physically assaulted, suffering long-term medical and mental health consequences to the point where they are no longer able to work. My colleagues and I spent years begging hospital leadership to take our safety and the safety of our patients seriously. Requests for additional security measures were continuously refused, stating they weren't in the budget. It wasn't until the last 6 months that hospital leadership allowed us to have one security officer in our department at all times, as well as a weapons detection system at our entrance. Hospital administrators care more about making money than helping their nurses and patients. We have no budget for additional nurses, techs, security officers, but our CEO can take home nearly $2 million in yearly pay and bonuses. This is not dangerous, it is also fiscally irresponsible. Let's talk about the cost to our patients. Delayed care, missed treatments, poor outcomes. How is that acceptable in a system meant to prioritize health? More and more frequently, we are experiencing longer and longer wait times in our triage area. Kids that are sick and requiring prompt medical attention are left waiting for hours before being able to be cared for by nurses and doctors. Early and swift treatment for these illnesses could be the difference between a patient being able to be sent home or not. We see this time and time again, especially during our respiratory season, with kids sick with RSV, influenza, and asthma exacerbations. We know that in hospitals with lower patient-to-nurse ratios, patients are less likely to be readmitted within 30 days, a key indicator for patient safety and quality of care. We're asking for a seat at the table. We're asking for hospital administration to listen, not just when it's convenient, but when it's hard. We're asking for resources to do our job safely and effectively, because the cost of doing nothing is a price we can no longer afford to pay. Thank you.
Good morning. Thank you for giving me the opportunity to speak today. My name is Jamie Wicklund. I'm a registered nurse at Children's Hospital in St. Paul with 25 years of experience at the bedside. I've cared for patients through joy and heartbreak, through miracles and tragedies. I chose this profession because I believe in it, because I believe that nursing is one of the most meaningful, human-centered jobs a person can do. I'm here today because I love this profession, but also because I've watched it become unsustainable for far too many of us. There's a crisis in healthcare, and it's not just about finances or facilities. It's about nurses, the people who care for the patients every day. One of the root causes driving nurses away from the bedside is clear: unsafe staffing ratios. Let me start with one number that should alarm every single hospital leader. Over 50% of new graduate nurses leave their first job within the first year. They're the next generation of caregivers, and they are walking out the door within months. Why? Because they're forced to deal with unsafe patient loads, have little support, and no breathing room. They either sink or swim, and far too many are sinking. But it's not just new graduates. This is affecting the seasoned nurses as well. Numbers like the ones I just mentioned are a warning. They reflect what so many of us feel shift after shift: moral distress, exhaustion, and the weight of being responsible for more patients than we can safely care for. We didn't become nurses to cut corners or apologize to patients for delays in care. We became nurses to care, fully, safely, and with excellence. But when the system doesn't give us the tools or the time, we are left in survival mode, and that's when nurses quit. Safe staffing ratios are not just a patient safety issue. They are a nurse retention strategy. We have mountains of evidence that better staffing leads to lower costs, fewer readmissions, shorter hospital stays, and fewer complications. But equally important, it keeps nurses at the bedside with our patients. It keeps us healthy, committed, and able to do our jobs with dignity and excellence. Right now, hospitals are spending millions on recruitment bonuses and traveler contracts, while ignoring the single most effective solution, fixing the working conditions that are pushing experienced nurses away. We're not asking for a miracle. We're asking for enforceable staffing standards, not suggestions, not shifting targets, but real written commitments in our contracts. That's how we retain experienced nurses. That's how we support new grads. That's how we protect our patients. Here's the truth. Nurses don't leave because they stop caring. We leave because we're being asked to deliver safe care in unsafe conditions, and that's not sustainable. We are ready to stay. We are ready to serve. To do that, though, we need staffing ratios that honor and respect our training, our limits, and our capacity to care for those who deserve it most, our patients. Thank you.
So as you have heard today from the nurses here with me, and as we have heard from the overwhelming majority of our members, staffing continues to be our #1 priority, and we will continue that fight through these negotiations and as long as it takes. We're happy to take any questions you have.
Chris, I'll just ask, staffing has been a core issue for more than 10 years. And each time it's been dealt with committees or discussions or bargained away for other things, which is just part of the bargaining process, I get that. But I hear the same issue coming back. I basically wonder how are you gonna have a better time at it this time than you did the prior times when you didn't get the ratios you wanted?
Well, I think the difference is this year, our collaborative proposal that hospitals in negotiations from the Twin Cities to the Twin Ports, the staffing proposal that we're putting forward contains ratios. It is a ratio proposal that would dictate the safe and appropriate number of nurses to care for the patients on each unit in all of our hospitals. It's a bold approach, and it's something that we, for years, as you've referenced, have tried to work with hospitals to come to a collaborative approach, using committees, talking together, but as you've heard from the stories that the nurses shared, that hasn't worked. We've been steamrolled, we've been ignored, and so enough is enough. Ratios are the answer.
And it's a collective group, but it's individual bargaining units. Have you had progress on this front with any of them, or have they been kind of unified in how they responded to this so far?
You know, at this point, a lot of hospitals who are in negotiations are pushing back because this is a bold approach that puts patients first. It doesn't allow hospitals to prioritize their bottom line. I can give an example at my own bargaining unit in Duluth. My employer is proposing, our contract currently has language that says staffing can't be determined solely by finances and the budget. That seems to be pretty straightforward language that centers the patient at the heart of our contract, and we believe that that is vital to the mission of healthcare. My employer has proposed to strike that language. Ask yourself why they are striking that language. If only so that they can, quite obviously, staff to the budget, not to patient needs. And that's an example of why we're proposing the staffing proposal we are, because patients need to be at the center of this.
I'm sure readers, viewers are going to wonder, 2019 was the longest strike by Illini nurses in Minnesota history. 2022 was numerically the largest nursing strike. So people are going to wonder what's in store in 2025. Are you considering using those kinds of extreme tools to get what you want this time around?
Certainly, we are exploring every tool in our toolbox. At this point, we're hopeful that hospitals will join us at the table and see the common vision of keeping patient health and safety at the center of these negotiations. If they don't, we're prepared to have those discussions with our members and take the steps that are necessary together.
If I can ask Caitlin, I just wanted to hear the conclusion of your story. I didn't know if you had mentioned workers' comp. I didn't know if you were injured or if you needed to take time off from your injury and your experience. Just the rest of that story.
I did get injured by getting kicked in the head, yes.
Okay. Well, I mean, there's injured and then there's having to take time off work injured. I didn't know how extensive it was if you need. Yeah.
Correct, I was off work.
Okay. Thank you.
Yep, you're welcome.
Any other questions?
Yeah, are there other new negotiations going on or new proposals that you were negotiating? in this?
Are you speaking to new bargaining units or new contract language?
Both.
Both.
If that's,
Yes, we have a number of new bargaining units who have organized and joined our joint M&A in the last year. So we have a number of clinic nurses as well as an ambulatory surgery center and hospice house in Duluth. We also have cath lab nurses here in the Twin Cities and the North Memorial Maple Grove Hospital, which just unionized as a bargaining unit. And they are all negotiating first contracts. And so we're working with them to also propose strong patient-forward, patient-centered language at those facilities.
What's the number then? The last night it was like 15,000. Is it about that many nurses involved?
It will be more this year, so we'll be probably closer back of the envelope here, so
Sure.
Probably closer to 17, I would guess, 1,000.
Okay. Has there been any progress? I mean, 3 years ago there were these creation of these committees, and there was at least the hope of, okay, we're going to meet face to face, we're going to talk about patient safety, and that wasn't everything you wanted, but it was the solution at the time. Did any of that help? Because there was some hope that that was going to work 3 years ago.
In my experience sitting through many of those committee meetings, there was constructive dialogue. We were able to have discussions with hospital leadership, but in the end, the ultimate decision around staffing remained with the people who are setting the budget, with the people who are administering the hospital, not the people who are administering patient care. And we think that that's a breakdown and a fundamental disconnect in our healthcare system. We believe that the people who are giving the care need to be the ones using their licenses, their years of training and expertise, their clinical judgment to determine what a patient needs. And that was not able to be achieved through those committees. And we believe nurses need to have the ultimate say on what is safe for the patients that they are treating. If hospitals and the public trust us to do our job, then they need to trust us to do that job fully.
Can you compare this at the time? I mean, it was the coming out of the pandemic, but still in the pandemic, and there was a lot of agitation. There was a lot of talk about patient safety, patients being upset. You're talking about some of the same issues now 3 years later. Are things that as bad as they were during the pandemic? Are they worse? I'm just wondering what the landscape that you're talking about compared to that pandemic.
I'm happy to have any of the other nurses here talk about what they're seeing. The members that I talk to as I travel the state and visit with members are really telling me that the pandemic certainly shined a big bright spotlight on the fundamental disconnect in our healthcare system, but those holes, those gaps in our coverage are still there, right? So we're still seeing people denied coverage, we're still seeing hospitals run short-staffed, we're still seeing delays in care because there's not enough staff to staff our operating rooms. We're still seeing wait times in emergency departments because there's not enough staff to triage patients who need care. These are things that have continued to grow, and it's a problem that's not going to be fixed until we as a society address it. And if nurses are the ones to drive that conversation forward, we're happy to do it. We're happy to lead the care team in the hospital as well as at the negotiating table.
I had one more question. You guys have done the kind of why they left surveys in the past, and you may have more on that in the future, but so there's why they left, but there's also the question of will they come back? I mean, you're talking about creating an environment that for more staffing, but are there more nurses out there to fill these jobs, even if you got them?
Absolutely. So Minnesota has more licensed nurses with Minnesota nursing licenses than ever before. Those are nurses who are choosing not to practice because they believe it's unsafe, because they believe they can't uphold their moral responsibility to provide safe, high-quality patient care. And those are nurses that we will come back when those conditions are provided. So again, we don't have a lack of nurses. I'd really like to clarify that. I will continue to say that until I'm blue in the face. We don't have a lack of nurses. We have a lack of nurses who are willing to work in these conditions.
What are the timetables right now? Is there a deadline by which these contracts must, and I know there might be a little different from Duluth to the Twin Cities.
So our contracts in Duluth expire at the end of June, and the contracts here in the Twin Cities expire at the end of May. So we're watching those deadlines together, talking as facilities who are bargaining in a coalition, and we're certainly looking at those dates as times that we need to see action from the hospitals and movement to significantly address our staffing crisis.